Hello, dear colleagues and friends. It's a great honor to be invited to speak in this prestigious meeting of Bangladesh International Cancer Congress held in Dhaka. My topic today is opportunities and challenges of radiotherapy in esophageal cancer, Shanghai experience. My name is Hongcheng Zhu. I'm a radiation oncologist from Fudan University, Shanghai Cancer Center, China. So what I will cover today is three main points. First is the perioperative setting. Is there still position for radiotherapy in immunotherapy era? Second, I will go for definitive chemoradiation. Let's figure out if there is still room improving outcomes for non-surgical approach. Last but not least, I will go for radiotherapy for management of olig and multi-metastatic or esophageal cancer, which has drawn increasing attention in recent years. Okay, something about me, a simple introduction of myself, not important, but I was alumni of the first class of ESMO latest generation program Asia dating back to 2090 with Dr. Mostafa Adil Sumon. Okay, let's move to the science. My talk will be based on international recognized clinical trials as well as our own experience in Shanghai. So I'm not going to talk about cross or float 4 study who has been established the standard of care of chemoradiotherapy or chemotherapy in management of resectable localized or local advanced disease. My first trial going to talk is about the ESO NEO trial took place across multiple centers in China. This phase 3 study investigate how effective and safe is it to add the PD-1 inhibitor camrelizumab to neoadjuvant chemotherapy. There has been a total of nearly 400 participants enrolled in this study, divided into 3 groups. One group received camrelizumab with MB, paclitaxel, and cisplatin, and another received camrelizumab with the normal paclitaxel and cisplatin, while the third group was treated with paclitaxel and cisplatin alone. The result demonstrated that adding camrelizumab significantly increased PCR rate with the group receiving camrelizumab plus MB paclitaxel achieving a PCR rate of 28%, and the cisplatin and pembrolizumab plus camrelizumab reached about 15% compared to just 4.7% in the chemotherapy alone group. Although these promising results highlighted the potential benefits of combining immunotherapy with chemotherapy, EFS data are yet not mature. And also, I would like to mention another study, ESO Shanghai 14 phase 2 trial, which we also provide insights for adding induction immunotherapy to concurrent chemoradiation. Although it is towards for non-surgical approachment, we found a higher local control rate through promoting vesicular normalization and elevating hypoxia, which suggests that induction immunotherapy followed by concurrent chemoradiation could be a potential option in the future. Post-operative studies have also been investigated, especially adjuvant chemotherapy, including MAGIC trial, or for adenocarcinoma, or JACO 9024 for squamous cell carcinoma. The Checkmate 577, whom has set up a standard of care of adjuvant immunotherapy after neoadjuvant chemoradiation. While it comes to adjuvant radiotherapy, there has been more controversy except for R1 and R2 scenarios. We have the opportunity to investigate post-operative chemoradiotherapy by 3 series of single-arm phase 2 studies, including Shanghai 9, Shanghai 12, and Shanghai 17, and find that adjuvant radiotherapy to a total dose of 50.4 gray by target volume of high-risk regional area periods and concurrently with chemotherapy was a feasible option for very select squamous cell carcinoma who had received surgery directly without neoadjuvant therapy. Next, let's move to definitive chemoradiation. I have been aware that there may be a little old school if we talk too much about RTOG 9405 today, although it is a classical piece of work. The RTOG 0617 for non-small cell lung cancer, which is a masterpiece as well, brings us the real thoracic radio-oncologist's answer to an old question is that in the new era, that is, higher dose was not better than standard dose for patients in many situations. For esophageal cancer, similar answers have been addressed in the new era in both Asian and non-Asian populations from phase 3 results, which are listed including both China and Europe. It is a question of dose to finish with answers. No or sorry. So our ongoing ESO Shanghai 12 study as well as the British Scope 2 study are trying to work out a PET-guided chemoradiotherapy option for patients from Asia and Europe. I have not have the answer right, but although I have opportunity to work with both of the teams, however, I believe that precision radiotherapy based on both biology and imaging will provide a new basis for individualized therapies in the future. And another old but important question for every radiation oncologist is the radiation field. And we observed different radiation field or category requirements in different guidelines or trial protocols. There is a phase 3 trial from China to compare involved field radiation to elective node radiation in concurrent chemoradiotherapy for esophageal cancer, which reported decreased esophagitis and pneumonitis were observed in the involved field irradiation arm, while similar survival outcome was reported in the two groups. Meanwhile, myself, I did a secondary analysis of the ESO Shanghai 1 trial, which was actually a chemotherapy regimen comparison trial, and we used the involved field irradiation method for all included patients. The current recurrence patterns of this trial just confirm that it's unnecessary to use elective node irradiation. Just spoken, the ESO Shanghai 1 chemotherapy regimen organization, we also did the ESO Shanghai 2 as well. To be simple, the answer is that different concurrent chemo regimen of like TF, PF, TP, TC are similar survival outcome, different toxicity profiles. Physicians can choose whichever their experience or preference. The result is generally similar to the concept of the French Prodigious 5 study, which support another regimen of FOLFOX, more commonly used in European countries. When talking about systematic therapies with radiotherapy, chemotherapy is not the only option. Previous attempt has been made by adding targeted therapies such as cetuximab in Scope 1 trial but failed. However, immunotherapy has been the pop star in esophageal cancer therapy today, especially we have witnessed so many exciting results of PD-1 or PD-L1 inhibitors in first line or second line therapies for metastatic esophageal cancer. And I'm proud of some from China as well. As well, we have evidence of adding immunotherapy in definitive chemoradiation for lung cancer, including the Pacific, Adric, and Gemstone 320 trials. While for esophageal cancer, there has also been trials for investigating adding immunotherapy to chemoradiation, but we haven't seen the full article published yet. Just hope if they can be as successful as these ocean studies. Finally, we have reached the metastatic setting, which is my favorite part, and the part for the future, I think. First, I will talk a little bit about our ESO 13 trial, which demonstrates that adding of local treatment for metastatic could significantly improve progression-free survival among patients with oligometastatic esophageal squamous cell carcinoma being treated with systematic therapy. I value this study being a very new era for local therapy, not only radiotherapy but other radiotherapy methodologies for management of advanced esophageal cancer. Before this study, radiation courts were like the intervention radiologists or even like the surgeons are not placed in the position to provide palliation, or we are like this position more for a diaphagia or pain or so, but this trial gave us a new position in the stage 4 disease. I won't say that this current study changed our guideline or position since it's only a phase 2 study and not randomized, but at least it's first time changed our attitude firstly with the solid data that we came towards a more positive attitude in the management of metastatic stage esophageal cancer, and of course with contribution of survival outcome improved by systematic therapies, especially immunotherapy. We are currently recruiting patients for the ESO Shanghai 12 phase 3 trial as well, which will further answer that if the combination of local intervention therapy with anti-PD-1 therapy is effective and safe for patients with oligometastatic esophageal squamous cell carcinoma. Just to clarify, I was not intended to say that palliative radiation therapy is old-fashioned or not promising in the previous slides. It is still a hot topic in the new era and have bring many new ideas and innovative approaches in the changing world of metastatic disease treatment landscape. I have seen the freshly published editorial in the Red Journal, which is a great source for those who want to have more information about the hidden benefits of palliative radiotherapy, which is not just palliative. And our international collaborative review also addressed the idea for the radiotherapy of advanced esophageal cancer, including from both population and curation with Dr. Sumon. Here comes to my conclusion, which is my personal opinions for the current opportunities and challenges. So first, is there still room for radiotherapy in the immunotherapy era for the perioperative setting? My answer is definitely yes. However, we must be aware that we are at the crossroad. Our situation is challenging, but luckily everything is ongoing. Second is definitive setting, is there still room improving outcome for non-surgical approach? My answer is yes as well. We are working in a multidisciplinary team and we can have novel agents and technologies from different specialities. Third, radiotherapy for management of oligo and multi-metastatic scenarios. It is the future playground for radiation oncologists. Maximum our contribution for improving the outcome for poor patients of esophageal cancer. So last but not least, I would like to talk a little bit about the medicine, science, and technology of China, which you do expect is more affordable or cost-effective or more high speed or premium quality, which are now currently exist. And we have the opportunity of radiotherapy training in Shanghai next year, which is an international training course or precision radiotherapy 2025 by China Ministry of Science and Technology. So we will call for participants who are interested in world-class radiotherapy technologies and multidisciplinary cancer care. We encourage highly motivated young or experienced professionals 2 weeks participation, both in person and virtually, and currently working in an institution from a developing country with collaborative attitude. So all the selected participants will benefit from free registration, free training materials as accommodation in Shanghai. Okay, thank you all. Thank you again for the organizers. And